Good morning, everyone. Welcome to this symposium that's entitled Establishing Malaria-Free Zones in Zanzibar and Zambia, Progress and Next Steps. We have a nice opportunity this morning to hear from two presenters from each of the countries working on this. That means that we have a nice amount of time for each presenter to give us a look and their perspective on this. We also recognize that we're competing with a number of other malaria sessions, so we appreciate your attendance to this one. This is a time and place where we're looking at increasing numbers of countries, identifying elimination, and trying to move it from just an aspiration into an actual reality. And I think that's certainly true for both of the countries that we're hearing from this morning. As chairpersons, we're meant to keep time and keep track of things. We'll have presentations followed by questions, and if there is time at the end, we can also open it up again to questions at the end. But we will plan to just do presentations and questions for each of the presentations. And with that, I'll turn over to Anders Bjorkman, my co-chair, and ask him to introduce our initial speakers.
Thank you. Yes, and we're moving first to Zanzibar, the two islands of Zanzibar, where malaria control was sort of initiated in a more in-depth way around 2003. So we're just about a decade ahead now of the results. So, and I'm pleased to have not the manager, but the deputy manager of the Malaria Control Program as the first speaker, Mr. Munim Selam, and he will tell us about the transition from high malaria transmission to a stage of pre-elimination, malaria control in Zanzibar during the last decade. So please, Muni.
Thank you, Anders. Good morning, everyone. Can you hear me? Okay. I'm presenting here on behalf of my program manager, who has another commitment, who didn't make it to come in this meeting. But this is his good opportunity to me also to have this session with you this time. As Anders said, we are presenting the transition of high malaria transmission to a stage of pre-elimination in Zanzibar. This is our presentation outline and background. In Zanzibar, malaria prevalence has dropped based on sentinel sites cross-sectional, which we conducted 2013, and there are some cross-sectionals which we conducted before, but this is the latest one, and we have realized that malaria prevalence is almost 0.3, and incidence rate is 1.9 cases per 1,000 population. This is based on our annual report of Zanzibar Malaria Elimination Program. For your information, now our office, our program, we have changed our name from Zanzibar Malaria Control Program, and now we're known as Zanzibar Malaria Elimination Program, and we want to try our best to be really malaria elimination program. Malaria transmission is perennial, but currently is high seasonality in some areas in some time. I think we'll see our presentations. We show what time and which areas malaria are very high. Transmission variations is hotspots, especially in urban areas. And robust surveillance, we have managed to have weekly reporting and daily case notification, use the suggested for epidemic detection and response and active case detection planning. In terms of interventions, what we did until when we reached there. We have very good universal coverage with integrated vector control interventions, which is long-lasting no ownerships, and based on Tanzania HIV malaria indicator survey, we have noticed the coverage of ownership of long-lasting net is almost 80%, and targeted indoor residual spraying is approaching almost 90% in all rounds which we implemented in our households level. And we are dealing with larva source management. This is a recently activity intervention which we started at least 3 years ago, but at least we are doing very good on this. We have very good universal access of malaria diagnostic in all public and private health facilities, which is microscope and malaria rapid diagnostic test. And we are glad to inform you that we have almost 100% coverage of these diagnostic methods in all health facilities. We have very good routine assessing quality and deliver services, which is malaria quality assurance and quality control of both malaria microscopy as well as rapid diagnostic test. We have regular load testing of all consignments which is coming in our islands in month, and we are rereading the slides from healthy facilities at least monthly. 10% of negative slides and all positive slides we reread at the central level. This is the impact. After doing all of them, this is how we have realized, if you observe malaria prevalence, these are bars, this big bars is malaria prevalence. From 1989, we had almost 40% of prevalence, and we have gone with this high prevalence until 2004, when we started to introduce our interventions. This is the interventions. For example, in use of insecticide-treated net, we introduced in 2002, and we are increasing dramatically whenever we go. And use of ACT in public health facility, we introduced in 2003, and as you've seen, we are almost 100% of coverage. And we have ACTs in, we have long-lasting net, we introduced somewhere here in 2002. We started with special population, but now we are using universal coverage. If you see indoor residual house spray, we introduced in 2005, and we are doing well on this. And RDT in public health facilities, we introduced somewhere 2005, but the coverage is good. So if you see, whenever we go, introduction or use of our interventions is increasing, but the prevalence is decreasing, and now we are happy to inform you that the prevalence is less than 1% for almost 5 years in Zanzibar, which is very good, and this is how we decided to go in pre-elimination in our interventions. If you see the admissions in our major hospitals, we have around 7 major hospitals which they have inpatient services in Zanzibar, and both under 5 as well as 5 years and above, there's a decreasing of number of cases admitted, and in general also is very low if you compare 2003 and 2012. Mortality trend also is going down. If you compare 2003 and where are we now, you will see, you will observe significant reduction of mortality in our health facilities. Now we are concentrating, we are doing surveillance system in Zanzibar, and we have started to introduce malaria early epidemic detection system, whereby health workers are submitting weekly reports through cell phones. Each health facilities, especially to start with public health facilities, we giving them mobile phone which they can report to the central level as well as to their district medical officer and district surveillance officer in weekly basis report. And the information which is reporting to our central level and as well as district level is from health facility, total outpatient attendance, total positive test, total negative results, and we are stratifying these results by age group, and information, as I said, that is submitted to the national, zonal, as well as to the district level. What inputs we get from these meets? First, we have website presentation into summary tables and chart. At the national level, district level, we can observe the results of each healthy facilities in terms of tables and charts. We have weekly reports to national level and stakeholders. At the program level, we are putting together all information from healthy facility, and we are giving a weekly report to national level at the Ministry of Health as well as our stakeholders, and quarterly reports to the healthy facility at district level. And we are providing this report in both two languages. In Zanzibar, mainly 100% of the people we speak using Swahili language, and at least 80% of people they can understand, write and speak English. So we are providing our result on benefit of our partners also. We have our partners, so we have to provide this report in both two languages for health workers as well as for our partners. And it allows for feedback as well as decision for undertaking. Surveillance system, and also we have introduced malaria case notification. And malaria case notification we introduced in 2008. First phase, we started with some as low transmission. We introduced National Malaria Case Register to help focalizing malaria resources as recommended by WHO. And second phase, we established malaria case notification, whereby individual case gets response once detected via mobile phones. As we said that we have mobile phones, and information from mobile phones, it goes to the district malaria surveillance officer, district medical officer, as well as at national level. So once when we receive information from the healthy facility, district malaria surveillance officer, which has located in each district, we have one district malaria surveillance officer with new motorbike, tablet, as well as mobile phones to receive and to manage to communicate properly with healthy facilities. So once when district malaria surveillance officer receives this information, immediately goes to the healthy facilities, collecting detailed information of index cases, and then they are following the index case to their respective areas, whereby household characteristics, including geo-located guests, are captured. And also household members get tested with using malaria rapid diagnostic test, and spot treatment are provided for all detected positive in that households where index case came from. I don't know if you can observe you can view my slide, but these are the summary table which show malaria case data from September 2012 up to August 2013. The left side here we have number of districts. In Zanzibar, both two islands. For those who are not familiar with Zanzibar, Zanzibar is composed with two major islands. We have Unguja and we have Pemba. And Zanzibar is semi-autonomous of United Republic of Tanzania. So we have 10 administrative districts, and we are putting our information in district data. And if you check this report for this period, we have managed to notify. There was about 2,516 cases has notified from different districts. The highest district was West District, which is located in Unguja Island, and the lowest one, it was Chake Chake, which is located in Pemba Island. If you see number of cases which followed up at the household level, we managed to follow up 75% of all reported cases in this period. 60% of those cases are completed follow-up. And when we say completed follow-up, means household visit marked complete. And number of household members enumerated during this follow-up, we enumerated around 80,000 household members. Out of them, 90% of them, they tested with malaria rapid diagnostic test. And we found new cases from that visit, around 512 cases from 2,000 516 cases which reported or notified through healthy facility. During visit or during investigation, we found another new 512, which can be asymptomatic cases. Out of them, there were 7%, and the increase of percent of increase of case found using malaria cause notification was almost 20%. And each district, it has own report. But this is the summary which I give you is the general in all 10 districts. Now we have stratified our shehias. Shehia in Zanzibar is the lowest government administration. We have national level, we have regions, we have district, and this is the lowest administrative level of the government, and we have, in each shehia, we have administrative leader, which we call sheha, and the total population of each shehia, minimum we have, lowest shehia, it has around 600 people, and the highest one is 3,500 population. So we have started to stratify based on the information which we received from the healthy facility. We stratified our shehias with the malaria level according to WHO levels. If you compare with the data of 2002-2005, by that time we had only 315 shehias, but now we have increased our shehias up to 332, and this basing on the increasing of population. Once population has increased, then respective shehia is divided into another shehia. So in 2002 we had only 315, but now we have 332. If you check high shehias by that time, which has more than 3 cases index, we had 165 shehias, but now we have only 77 shehias. And moderate shehias, by that time, 2002, we had 139 shehias, and now we have 84. Low shehias with prevalence of cases, we had 11 shehias, and now we have 99. We had no free, and this period, this categorization, we categorized in 3 months. So for almost 3 months now, we have 72 shehias which has reported any case to our healthy facility. So we can categorize these as free shehias with malaria incidences. So we want to manage, we want to expand these shehias to improve and then to maintain these shehias to be free. So this is good improvement. We didn't have any shehia which has free, malaria-free zone, but now we have almost 72, and this is 3 months records. So every after 3 months we count how many shehias. Do we maintain this 72, or we will drop? But I think we will maintain. The way forward, we want to have strategies to maintain and increase zero cases zones. As I said that we have 77, but we want to maintain, whether to maintain 77 or to increase more malaria-free zones in our islands. And by doing this, we want to scale up universal surveillance system, including 100% private health facilities. The information which I shared you in my summary table is only from 100% of public health facilities and some pilot private health facilities, only 3 out of 72 private health facilities, which is in Zanzibar. So by the end of this time, we want to have 100% of private health facility. We want to expand screening during investigation. Now we are screening only household level, but we want to go to the nearby indexes, nearby household neighbors. Also, we want to introduce primaquine for radical treatment for those asymptomatic and gametocyte carriage. And also, we want to continue, monitor, and evaluate anti-malaria interventions, including long-lasting net IRS utilization and coverage at household level. And we want to reinforce behavior change communication to both community as well as healthy workers. and we want to emphasize fever-seeking behavior in our health facilities as well as community. By doing this, we acknowledge a lot to the Ministry of Health, United States of America Development Agency, and Karolinska Institute health workers in all 6 delivery points, as well as community of Zanzibar for this good work which we are working together. Asanteni sana. This is thank you in Swahili.
Asante sana. Asante sana, Mwenye. Okay, so we have time for a few questions, clarifications, or also comments to the program. Yes, please. Yes. Is there a, yes. Yeah. And please identify yourself before the question.
Hi, Colin Orr, UCSF, Malaria Elimination Group. Winnie, what do you do differently in malaria-free areas now, if anything?
Now, as I showed in my last slide, that we are still keeping investigation to the cases, as well as emphasizing, especially for advocacy and sensitization to the community. They shouldn't relax. They have to maintain use of interventions, as well as any seeking behavior, any fever-seeking behavior. Any fever, people, they have to report to the health facility and get treatment if they have malaria. But in terms of control interventions, we are making sure that the coverage of our control interventions is maintained. And soon we want to introduce this continuous distribution of long-lasting net.
Do you have scientific data, research data on if you broaden the radius, what impact, additional impact will that have around your case?
Pardon?
If you go larger around the household to a larger radius, how many additional cases will you detect? Do you have any data yet?
As I showed in my slide, that in that period we had around 2,500 cases, but when we go to the detection, we found new cases 500 and something. But per household is sometimes we get, sometimes is very low. But if you check the percentage over there, it's almost 0.5 case per
and
each
if you
index
do a
case.
larger sample around the household, do you have data yet? Not yet.
Not yet.
Okay, and the last question is what percentage of your cases are imported, and where are they coming from, and is the military an issue?
Yeah, we are not sure if there are malaria imported from Zanzibar, but we have at least a travel history of individuals. So around that cases which we report, almost 30% of people we found that they had travel history previous 1 month, and travel history we define as outside of their respective districts. So sometimes they had travel history of outside of their district, or sometimes we had around 14% of them, they were outside of Zanzibar. But we are not sure this malaria is imported outside from where they went to visit. But at least they had travel history.
Okay, Larry?
Yes, thank you. Larry Slutzker, CDC, and congratulations on a really great success story in Zanzibar and hopefully a continued progress. My question is about, you showed that you stratified some of the shahiyas into high, medium, and low and free. I wonder if you have any plans to do additional kinds of active case finding based on the stratification, things like mass screening and treatment or focal screening and treatment in those shahiyas based on your stratification levels.
Yeah. We are conducting, right now we have started to conduct active case detection, especially in shahiyas where they have very high incidences of cases. We are monitoring and we are conducting active case detections. And also sometimes we are conducting proactive and active in all areas. But we have not started any intervention to the free areas, but to the increasing shahiyas, we are conducting active case detection, and we have managed, or we are providing extra intervention, for example, indoor residual house spray, distribution of long-lasting net, and we have attempted once in 3 shehiyas, we conducted even malaria mass drug administration in 3 shehiyas, when we found that all interventions which we implemented did not succeed. Still, transmission was high. We introduced or we implemented mass drug administration to whole community in that respective shehiyas.
Okay, please, 2 more questions.
Marty Cetron, CDC. Add my congratulations to others, a really impressive effort. I noticed that many of the interventions were implemented concurrently, and so it may be difficult to tease this out. But from looking at your data, have you stratified to see the relative contributions of impact of the different interventions, or can you say from the areas where there's residual high or low what the relative contribution of the various interventions has been?
No, we have not assessed that one. And a good thing of Zanzibar, when we introduced all our interventions were introduced in all areas. So we have not assessed which intervention is very high in which area. So our interventions is universal in all shehiyas.
Okay, Akira?
Akira Kaneko, Karolinska Institute. You showed 76 malaria-free shahiyas in your table. So what is the characteristics of those shahiyas? Are they isolated? They did good work? Or why they are free of malaria?
Thank you. We have not assessed that one, why they are free compared to other shehiyas, but I think we have to work on that and see why they are free and others are not free. But what we believe that reduction of cases is going dramatical. So we started with this 77 shehiyas and other will follow. But we don't have scientific evidence why there are difference between this and the high and moderate or low shehiyas.
Okay, one more question.
Yeah, 6th PMI Madagascar. Zanzibar being an island and Madagascar being an island, though the sizes are very different, I'm trying to know, are there any measures in place to control imported malaria? Is there anything that you do to get the tourists screened, or any measures to really know what is coming in from outside?
Yeah, we are planning to do that. Right now, we are starting to deal with the local cases, as we see that there are still focalized areas. There are some transmission hotspots within Zanzibar. So once when we manage to control focal or malaria within Zanzibar, then we will deal with the imported cases. But right now, we are dealing only with the local cases.
Thank you. Thank you, Muye. And now we move to the next talk regarding Zanzibar. And we will hear more about the sort of challenges and opportunities that have come in recent years for the pursuit of elimination, further elimination of malaria in Zanzibar. Please, Dr. Andreas Mortensson.
Good morning, everybody, and welcome to the symposium. And first of all, I would like to acknowledge Jackie Cook, who has been instrumental for this presentation. A lot of the data that I will show is actually based on work that she has been responsible for. And also thanks to Mwini for introducing us to the Zanzibar context. So present and future challenges for surveillance in the new context of very low malaria transmission in Zanzibar, and to potentially fulfill the official goal of malaria elimination. As Mwini pointed out, malaria in Zanzibar has decreased substantially over the last decade, and we believe the surveillance system is comprehensive. We have the MEADS system, and we have also malaria case notification in place. However, those programs are good to handle the number of symptomatic malaria infections, the relatively high parasite density infections. But depending on the diagnostic tool that you're using, you may get different understanding of the total burden of malaria infections and the reservoir in Zanzibar. So this is data from 2 cross-sectional surveys that we conducted in both Pemba Island, Michiwene district, and Unguja, North A district in 2009 and 2011. In those 2 cross-sectional surveys, we found hardly any parasite carriers using the traditional diagnostic tools, microscopy 2009 and RDTs, rapid diagnostic test 2011. However, when you screen all those samples with highly sensitive molecular tools, PCR, then you get a different understanding of the parasite reservoir. In 2009, in Michiwene, we found 5% parasite positives, a large proportion being P. falciparum, but we also found a substantial P. malaria infection and mixed infections. 2011, when we repeated this, we found 3.3% positives. In Unguja, North A, we found also a parasite reservoir, even though that parasite reservoir was of less dignity, around 1 to 1.5%. But this is important. Depending on the diagnostic tool that you're using, you get different understanding. We believe that the asymptomatic low-density parasite reservoirs may represent a key challenge for malaria surveillance in Zanzibar and to reach malaria elimination. This reservoir may be the cause of sustained malaria transmission, and as I mentioned, microscopy and RDT are not optimal to detect those low-density infections. Molecular tools are more likely, since they're more highly sensitive. However, PCR is not presently done in-country, in Zanzibar, which is a problem, and of course PCR is unsuitable for point-of-care diagnosis. Still, the PCR data may be very useful for looking at spatial distribution of infection, to understand the microepidemiology, which is very important when you're going to tailor your interventions. Heterogeneity, that has come up as an important characteristic of the new malaria epidemiology context in Zanzibar. As Moini pointed out, the transmission is no longer perennial. It's highly seasonal, where 85% approximately of the annual cases are detected during an 8-week period. And it's also highly focal, with 75% of the annual cases detected in approximately 20% of the health facilities. And it might also be so that the higher numbers recorded of symptomatic cases may also represent areas with a lot of asymptomatic infections in these communities. These are hotspots of malaria transmission, and these need to be targeted. I'd like to try to get you to understand a little bit more the focality of transmission, and it is clearly linked to some weeks, 8 weeks in the beginning of the year, week 19 to 27, just after the long rains, where we normally see a very high caseloads. And that was absolutely the case both for 2011 and 2013. However, in 2012, it was a slightly different pattern. We had more extensive short rains, which created a more pronounced increase in caseloads during the very early part of the year, whereas week 19 to 27 was not as many cases. So if we look at the hotspots in Unguja over the years, we see that 2011 and 2013, when there was a very defined peak during week 19 to 27, we found a number of health facility catchment areas which have high caseloads. And I identified this as a heat map indicating the catchment areas with 10% highest annual incidence. In 2012, it was slightly different, even though most of those catchment areas are also hotspots during 2011 and 2013. If you look over time between week 17 and 28, you see that the cases accumulate over time, and you see that the hotspots are centralized to the center and southern area of Unguja Island, with an increasing incidence. If you look at 2012, when we had this slightly different pattern during week 17 to 21, it is slightly different. Still, in the central and southern parts, there are the catchment areas with the highest incidence. And going back to, this should be 2000. This is 2013. Going back to a similar pattern, so this is not 2011, 2013, a similar pattern as we saw during 2011. Right. So how can we target these hotspots? There are several ways, which most of them are already in place. Focal indoor residual spraying has been conducted several times in most of those hotspots. There was a large distribution of long-lasting insecticidal nets with universal coverage in early 2012. Environmental management and larviciding is ongoing. There's been some attempt to do active case detection or even proactive case detection, but the evidence base for this has not been good enough. So we went to the field to try to get more evidence on proactive case detection using rapid diagnostic test. And we compared that to PCR. And I will present to you some preliminary data from this study that we conducted in 2012. The aim of this proactive case detection was to find and treat asymptomatic parasite carriers in the community in order to prevent the seasonal increase of symptomatic cases that we have seen very pronounced in these hotspots. We identified 13 hotspot shehiyas through the MEADS data. 5 of those shehiyas were randomly allocated to intervention and 8 to control. And the estimated population in intervention and control areas were 10,000 each. We did 2 rounds of ACDs, and they took place before the long rains, with 4 weeks apart. We had 30 teams of health students, 2 in each team, and it took them 4 days in each round to conduct house-to-house screening of the interventional shehiyas. We collected data on temperature, we performed the RDTs, we collected also filter paper samples for PCR, we asked questions about behavior, and we recorded the GPS position of each household. The rapid diagnostic test positive individuals were all provided first-line treatment with ACT, and we also collected data on confirmed malaria infection from all health facilities, both in the intervention and control areas up to 15 months after the intervention. So the results. During the first round of screen and treat, we tested 6,412 people from 2,127 houses. In the second round, we identified 4,830 people in the same number of households. In the first round, we identified only 12 RDT positive individuals, and in the second round, 8. That corresponds to a positivity rate by RDT of approximately 0.2%. Based on the population estimates, this survey was not complete. We identified 58% of the target population in the first round and 47% during the second round. The refusal rates were 4.3% in the first round and 13%, so it increased in the second round. And we even had one shehia with up to 25% refusal rate. However, the reported sleeping under net were quite high, with 70% reported that they slept under a net the night before the survey. So subpatent infections detected by PCR in the later stage. These are preliminary data from the first round. I want to point out this is really preliminary. 12 RDT positives during the first round, but we found 225 by PCR. So the positivity rate with molecular techniques was 3.6% instead of the 0.2% estimated by RDT. By PCR, 80% were P. falciparum monoinfections, 10% were P. malaria, and 10% were mixed infections. We found PCR positives in all Shahias, notably. If you look at PCR positivity across age groups, it's no longer the youngest children below 5 years of age that are most likely to carry parasitaemia. In this screen and treat study, we found that the highest group with the highest positivity rate was in older or young adults, 15 to 25 years of age. And the median age of PCR detection was 18 years. This is a snapshot and a kind of an appetizer for you to see the spatial analysis that we have just started, and that's in progress. Since we have the GPS position of the households and we have data on PCR positivity and oddity and PCR positivity, we can map this and try to identify clustering. And we like to look, of course, of clustering amongst the PCR positive cases, but also to look at clustering around RDT positives. There was one question before: how far in the diameter, in the radius, should you test around an index case? And this is information that we are trying to gather with this kind of analysis. It may also be that the clustering of P. falciparum versus P. malaria infections are different. So that is something that we are going to look into with quite some interest. This is also data in progress. We are working on that. So conclusion from this ACD study, and these are the conclusions for now. PCR apparently revealed many more infections than conventional rapid diagnostic tests. Screen and treat with MRDT did not reduce transmission. Refusal rates were high for the second round, and we need to improve community awareness of this kind of intervention, and so people and the community understands its importance. And we also have to ask ourselves whether 2 rounds of screening is actually needed from a cost-effective point of view. We were not able to survey everyone in the targeted Shias. That's important. Many people were absent, especially young men, which we have identified as the biggest risk group for PCR-detectable parasitaemia. So we have to ask ourselves, how can we target this risk group in a better way, in a more efficient way? Apparently, it's vital to identify and treat all parasite infections if we're going to pursue malaria elimination in Zanzibar. So how can these results help to inform programmatic activities? The pro-ACD study that we did with MRDT detected very few cases and did not reduce seasonal transmission. That's important. So we need more sensitive diagnostic tools for this. We need also a diagnostic tool that gives results in less than 1 year that actually PCR is doing right now. We have one potential such tool, loop-mediated isothermal amplification, a molecular-based method. And actually, the reason why Jackie is not here today is that she's right now in the field performing a pilot study on LAMP in Zanzibar. The spatial analysis may help us to identify hotspots within the hotspots, so to understand better the microepidemiology, so we can better target vector control measures in these areas. And the spatial analysis may also help us to decide a good screening area around the cases. We do not actually have good evidence base for that presently. Cost benefits. Is screen and treat a way forward? That is also something we have to ask ourselves. Should we instead have maybe focal mass treatment? I have mentioned a number of challenges, and the first 3 points have already been discussed quite much in detail. The revealed reservoir of low-density parasitaemias, the heterogeneity that we have seen now in the malaria transmission, and also the changing in age distribution, meaning that children under 5 years are no longer the biggest risk group. We have also other challenges. The temporal decline in herd immunity may be an important factor. And we believe that Zanzibar may be more and more epidemic prone in the future as the herd immunity declines. The imported malaria cases are of course important, but we do not really know for sure the relative importance of travel, even though we have identified that as a risk factor. We are also worried about the threats of resistance, both to ACTs, and we need to monitor that carefully. And we also know that there are pyrethroid resistance documented, both from Pemba Island and from Unguja nowadays. Importantly, we have opportunities also. We have, as pointed out by Winnie, a very comprehensive surveillance system involving many different aspects. We have new tools and strategies that we may be able to implement in programmatic activities in the near future, but we need to gain evidence base on them. For example, more sensitive diagnostic tools like LAMP. We also have serology that could assist to assess trends in malaria exposure. We have a very good health infrastructure in Zanzibar, and we need to build on that. Adherence to RDT results have been very high, and we need to make sure that continues. RDT has also been incorporated in the integrated management of childhood illnesses in Zanzibar, which is important. And we also need to address the non-malarial fevers in parallel to the malaria interventions. We also have unutilized tools in the toolbox. Seasonal malaria chemoprophylaxis or focal mass screening or drug administration is one of them. And transmission-blocking drugs like primaquine has not been utilized to a large extent as yet. So, if malaria elimination in Zanzibar is going to be a realistic goal, we probably need even more and new additional tools in addition to what I have already spoken about. But what they would be and contain of is presently not clear. And in addition, we need also sustainability of the interventions and funding. We need the political commitment, both domestic, regional, and globally, and probably also other factors. And with that, I would like to thank you very much and ask you to pay attention to some of the very important key players in these studies that we are doing, and especially then Jackie Cook, who have contributed a lot to this presentation. Thank you very much.
Thank you, Andreas. And I see that already now 4 questions. Okay. I think we have time for a couple of them, so please.
Again, congratulations to you and to the wonderful effort. The question about sort of icebergs and
please
icebergs.
Identify yourself.
Oh, I'm sorry, Tom Ritchie, independent malaria consultant currently. But I used to run the Navy's malaria vaccine program. So my question is, obviously, if you switch from RDTs to the current molecular diagnostics, you pick up a hugely larger number of cases. But obviously, there's a concern that there's an even larger number of cases with parasitaemia below the level of detection using current molecular techniques. And I'm wondering if you have any handle on that, and if, for example, you followed individuals longitudinally and perhaps identified that on week 1 they were negative with molecular diagnostics, but just spontaneously became positive maybe 2 or 3 weeks later. Do you have any feeling for that iceberg below the iceberg?
That's a very good question, and we do not have the full understanding of this parasite reservoir, and we actually do not really know the contribution, the relative contribution for transmission. That's also important to underline. We have done a small sub-study where we went back to some of those individuals from the cross-sectional survey 2013 that were PCR positive. 3 months after, around 30 to 40% of them remained PCR positive, but we do not have data in between.
Is that after with treatment?
No, that was without treatment.
I see.
Right.
Okay.
Yeah. So some of them apparently remain positive, right? But we have not treated them and went back to them and checked in a.
I mean, you might be able to use mathematical modeling.
Absolutely.
If you collect some longitudinal data, and it'll give you a sense of how
right.
big that, because it may be critical.
Right. And maybe we should discuss that after this symposium.
Hi, David Caslow from PATH. Excellent talk and fascinating results. So one of the questions obviously is of those individuals who are PCR positive, which of those individuals are actually a reservoir for transmission? And so one of the tools that's being used in the controlled human malaria infection model to look for individuals who may be transmittable but you don't see gametocytes on smear is to look for transcripts of some of the sexual parasites. So I'm wondering if you have any information on PCR positivity and gametocyte transcript positivity, or is that something you can look at?
Unfortunately, I do not have that this year, but I hope to be able to present that next year.
Pierre Buffet from Paris University. Have you made some clinical examination on the positive as compared to some controls? I'm thinking of obviously fever, but I guess they're asymptomatic, or spleen size.
They were asymptomatic. They did not have fever or history of fever, but spleen size was not measured.
Eli Schwartz from Israel. Excellent presentation, and it seems that you are focusing on the hotspots within the island of Zanzibar, looking at Zanzibar like a really isolated place. But I wonder whether the main hotspot is the mainland. Don't forget that geographically it's very close by. There's thousands of people, as I estimated, moving back and forth every day. So actually, how can you control this movement? Or to continue, do you have any information about the anopheline population within the island, whether it's declining or not? So what's the future with the, as I mentioned, bigger hotspot nearby?
Right. Unfortunately, I'm not an entomologist. Maybe Silas is here who knows this by heart. The other question, though, the relative importance of imported malaria is unclear for the time being, and maybe Winnie could respond better than me to what the program is planning to do. We, as you, believe that importation may be more and more important as we move towards elimination, since we know we have a parasite reservoir that is large in mainland, and we have thousands of people traveling between the islands and mainland every day. Some of them are traveling in authorized vehicles, some in unauthorized, and I think the latter is really the challenge. We can potentially screen the ones going by ferry and plane, but in the unauthorized vehicles, that would be very difficult. So we will remain to have this threat of reimportation for a very long time.
So one last question, please. Larry again.
Thank you. Thanks very much. Great contribution to understanding what we can or cannot do or might be able to do with mass screen and treat. I appreciate that. Both speakers now have, Larry Slutzker, CDC. Did I say that? Anyway, I can't remember what I said. Both speakers have mentioned the use of primaquine, presumably low-dose primaquine, and I wonder if you could just give us a brief overview of what the plans are to either use or pilot or implement that in the context of the control program.
Right. And maybe, Winnie, you should answer this question. It has been used very little up to now, but with the plans, the future plans, maybe you could answer this so it becomes directly.
Thank you for this question. I think Zanzibar, we are planning to introduce use of primaquine as a single dose. We will start with symptomatic people, and we have we are revising our treatment guideline now to introduce primaquine soon. So, and later on, based on these findings which we find, I think we'll go also to asymptomatic people. But now we want to start with symptomatic people in the healthy facility to have at least a single dose. But the question is when? Which doses? Should be direct under observation? It should be first day or the last day of our artemisinin-based combination therapy treatment. So these are this discussion. It has to be discussed further, and based on this kind of discussion, and we will invite some experts during our revision of our treatment guideline in Zanzibar soon.
Thank you, Muni. And to follow up, I think we're a pilot study before introduction. I think is what we plan for also. Please, Rick.
Okay. Thank you very much. And we're now going to move from Zanzibar to Zambia, and they probably have the only similarity in the name of the country beginning with a Z. As was just noted, the situation in Zanzibar, it's surrounded by ocean. Zambia happens to be surrounded by 8 malaria endemic countries. We're going to first hear from Busiko Harmansa from the National Malaria Control Program, and he's going to talk to us about malaria elimination activities in Zambia, approaches, progress, and future perspectives.
Good morning, everyone. Thank you very much, Rick. So maybe to get the ball rolling, just to give a perspective in terms of background with regard to the malaria situation in Zambia. In the recent past, we've seen that we have had some great strides in controlling malaria in the country. And as the malaria burden has been reducing in Zambia, we've further noticed that the disease burden is actually becoming more and more focalized. And in this regard, we've actually got areas in Zambia which have less than 5% parasitaemia, which, of course, as you know, is WHO pre-elimination criteria. So in this regard, Zambia has gotten onto a ambitious program where we're trying to at least document 5 areas or zones to be malaria-free by 2015. So essentially, this idea is basically going to be enshrined in focusing on surveillance to be able to identify focal patterns of distribution of disease, to target interventions more effectively and accordingly, to detect, of course, parasite reservoirs and those asymptomatic individuals, and, of course, to generate surveillance data to monitor and evaluate the progress towards this particular agenda of elimination. And essentially, we want to implement this kind of approach at all the different levels or tiers in the health system, including the community level, using existing community networks. So this slide is just to basically show you where we have come from. We have seen that we have an increase in terms of ownership of ITN and use. We have increased coverage of IRS. We also have increased coverage of IPT, intermittent presumptive therapy in pregnancy. Additionally, we've also noticed that we have had some reductions in terms of malaria admissions and, of course, a corresponding reduction in the number of deaths due to malaria in the recent past years. So we've successfully conducted about 4 malaria indicator surveys from 2006 up until the last one was in 2012. And these 4 maps just basically illustrate where we have come from and where we are in terms of parasite prevalence in under 5 children. You can see that the darker colors, of course, signify a higher level of parasite prevalence, and the lighter colors signify a lower parasite prevalence. And you can see that over the years, certain areas have had an appreciable decline as opposed to others at a provincial level. So, in essence, what we had to take into consideration when we were having this discussion about how are we going to measure our progress was we realized the fact that we cannot use cluster surveys really to guide and measure progress for an elimination agenda. And we realized that as a program, as well as at provincial level, at district level, there was a need to have more focal, granular data to sort of measure where we are and be able to target interventions accordingly. And of course, there are already set definitions in terms of the elimination agenda. And we need to understand when we are moving from control to pre-elimination and to an elimination phase. So we were fortunate that when we started these discussions, we had a revision of our health management information system. And we had some indicators that we're looking at including reporting confirmed cases of malaria. So this was really a plus for us as opposed to before when we were looking at fever as a confirmatory diagnosis for malaria. And we needed, of course, to consider the aspect of linking the burden of disease with the availability of commodities, in this case, the drugs, of course, and the rapid diagnostic test for confirming whether an individual has malaria or not. So we also required a way to be able to present this sort of information for us to make appropriate decisions and program implementation activities in these different areas. So just to illustrate, these are the clusters that we use for our malaria indicator survey. They are representative of the country, and we get a sense of the level of coverage and the utilization of our key interventions. However, you will notice that they are really far and few for us to really be using these as a basis for an elimination agenda. So similarly, this one is just to illustrate the health facilities that we've got dotted around the country. There are definitely more health facilities than there are clusters. And you can see that we have a focal pattern of disease at health facility level, with the bigger dots, of course, representing higher levels of transmission. So, in this regard, when we look at some of the work that has been done by Kent and Rick, in this particular publication, they basically advised the malaria community that it's important for us to have real-time data and for us to be able to identify residual infections. And one way that was proposed that we do this is, of course, by strengthening surveillance and increasing diagnostic capacity, monitoring and evaluation systems that, of course, provide us with real-time information that we could use for policy decision-making. And additionally, they also recommended that we use a community-based approach in addition to what is existing with regard to our health facility data. Additionally, there was some work done by Smith and then later by Killeen, who looked at this, who illustrated what sort of intervention package that we require as we are going towards elimination. And you will notice that right at the bottom, they're talking about being able to identify asymptomatic cases and using drugs to basically eliminate the reservoir of infection. So in this regard, really, we're talking about using surveillance as an intervention, really to look at epidemiological and remedial action to detect cases, to discover transmission, establish its causes, evaluate or eliminate the residual foci. And this is also, of course, to ensure that we are really monitoring ourselves as we're going towards the elimination agenda. So I'm going to use Southern Province as an example where some of these activities are actually being conducted. So Zambia has adopted what we're calling the three-step approach. In step one, we are basically looking at improving surveillance at facility level, which is basically a passive activity. And then step two, we're looking at mass screen and treat campaigns in those areas that have been designated as moderate to high transmission areas. And step three, we're looking at case identification, then we track and then test and treat communities associated to where that particular case has been discovered. So more to look at the step one activity is that we have what we call the Malaria Rapid Reporting System, which is a mobile phone-based reporting system, which is weekly, and this is based at the health facility level. And we have basically information on disease burden disaggregated by age on a weekly basis. And this gives us a certain sense of what is actually happening in the catchment population of that particular health facility in real time. So this is just an illustration of the dashboard that you get from this rapid malaria reporting system. It has capabilities for us to actually do some mapping, and it is accessible at all the different levels of the health system, including the health facility itself, where the people who actually submit this information can check on their phones and look at their trend data. And we believe that is also important for them to appreciate that the information that they're actually submitting is of some value and some use. For the mass screen and treat campaigns, which is our step two, the idea behind this is really to try and reduce malaria transmission in the selected area, for it basically to be able to qualify for what we're going to talk about a little bit later on step two, looking at community-based surveillance. And the idea behind this is that a catchment population is selected, and then we have a community-based response where we test and treat an entire community, usually done during the time of the dry season when we expect the transmission is low, and of course vector capacity is also low. So recently we had conducted one of these activities this year, and we found that we had positivity rates of about 26% on average, and it ranged from less than 1% to actually over 50% in certain areas. So this again just adds to the fact that we have focal transmission in Zambia. And this is just to illustrate some findings from 4 districts. and represented by the health facility catchment populations. You can see that we've got areas above 50% parasite prevalence, and there are some areas which are about 1.2 and less percent parasite prevalence in Zambia. So for step 3, this is what we call our community level surveillance. Basically what it is that we identify a person with a malaria infection at a health facility level or at a community health post level, and this particular individual is tested and treated, and then after that, that particular individual we initiate a reactive case finding activity where we go and test individuals within that particular person's households and those surrounding that particular person's households. So right now, our radius is approximately about 150 meters. We estimate it by advising the communities to estimate about the size of a football pitch, or maybe, since I'm in America, soccer. So a soccer field, which is about 100 meters, and like one soccer field and a half, and that is our estimate for the radius. So you can see, as illustrated in the picture there, that our index case was found with the dot represented by the green, and then the yellow dots are households that were basically screened and treated during that kind of visit. And of course, this information is recorded in our community health worker registers and transmitted through our DHIS2 system through mobile phones. So just to illustrate what we had found earlier on this year, the health posts that are manned by community health workers basically treated and identified about 850 malaria cases. During the same time, as a result of the active or the reactive case detection, we were able to find, using the step 3 system, about 718 individuals that were malaria positive by RDT. So essentially, that particular population of individuals would not have sought care and would have maintained to be a parasite reservoir if this activity was not conducted. So further still, another example of Kazungula district within Southern Province is we have 22 health facilities in Kazungula, as illustrated by that particular map. When we layer in the community health worker aspect, we not only have improved access to care, but we've also had an increase of about 160 data points that we can use, basically increasing our coverage of our focal data for malaria transmission or disease burden. So we always keep asking ourselves where we are in this very famous continuum towards elimination as a country, as a province, as a district, and even as a catchment, as a community catchment population. So we always have to also be rooted in the fact that we need to also measure our progress towards this elimination agenda. So we've set up certain milestones and targets. Looking at positivity rate, of course, we're looking at less than 5% for pre-elimination, and the number of cases confirmed of malaria cases, and we're looking at less than 1 per 1,000 population per year, which is looking at an elimination stage. So I would just like to acknowledge that we have various and excellent partners in Zambia that have been involved in doing all this work under the leadership of the Ministry of Health, and I'd like to thank you for your attention. Thank you.
Thank you very much, Busiku, and the floor is open for questions. And please identify yourself.
My name is Jean Capps, and I am a consultant, and I work in health systems, but when it's in Zambia, it always involves malaria. I was wondering, this is very exciting information that you have, and we appreciate the challenges that the Ministry of Health has in the information system in Zambia. I'm wondering, from your perspective, especially integrating the community health workers into the information system, what could be helpful from a donor perspective? Everyone acknowledges the challenges, but from your perspective, what would make this information more quickly available to you and sustainable?
Thank you very much for that question. Yeah, in fact, in Zambia right now, we are in discussions about what we're calling a community health management information system. And we're fortunate in that we've been having increased capacity building in the DHIS2 platform, which is a platform that we've been using for this real-time data capture. So there is discussions going on about how we can basically sustain community-based approaches towards, strengthening malaria control information. So it's in its infancy right now, and the beauty about the system that we are using is that it has now basically been integrated into our mainstream health management information system, which makes it easier to actually consider in terms of trying to scale up and push this countrywide. So we are using this in Southern Province right now, really as a pilot and as an operational research activity. But from what we are seeing so far, it's something that we'd like to scale up to the rest of the country.
Thanks, and again, congratulations on some great success and really interesting data. You showed that mass screen and treat series of, or there's a lot of information on that slide, but I just wonder if you could sort of, I know you're getting a lot of information about the focality of infection and so forth, but it didn't look like on first glance you were seeing a lot of impact on transmission. I wonder if you could comment on your plan, for future plans for mass screen and treat.
Yeah. Thank you very much for that question. So the mass screen and treat activities are basically complementary to what we already have in terms of our package of interventions. So we are layering this on top of IRS, on top of ITNs, and on top of the other malaria control interventions. So we're not taking away in these areas where we are using this particular activity. Yeah, it's a challenging question, and right now it's very difficult to sort of put in a certain level of attribution for these activities. So far, what we have seen is that there has been a reduction in burden of disease in the areas where we have implemented these activities. I think the last estimate we had was somewhere around the region of about 40 to 50%. But though we are still gathering more information to see if this is enough or we need other tools to add on for our elimination agenda. So it's really still a question that hasn't been adequately answered, and is still open for discussion.
Busiko, thank you very much.
Thank you.
And we'll now turn, I'm sorry, one more question.
Just one, and thank you very much for a great presentation. I was just wondering, do you have specialized vector responses when you have these hotspots, these cases?
Well, apart from the routine distribution of nets and the IRIS campaigns, there is no special vector response in these particular areas.
Thanks again. Thank you. So we'll move to our final presentation. This will be given by Dan Bridges, who comes from one of the partners that Busiko mentioned, from Acros Research based in Lusaka. And Dan is going to talk to us about progress in surveillance and active case detection in Lusaka district.
Okay, so I slimmed down my title because I was obviously being a bit verbose the day that I wrote it. So I'm going to talk about progress in malaria surveillance in Zambia, and I'm going to talk a bit about the molecular techniques, and hopefully this is going to change. Right. Okay, so the contents of my talk, I'm going to talk about this scalable surveillance systems. We've had quite a few different types of system that have been implemented, and I'll try and take you through those and the strengths and weaknesses of each. So the first one that I'm going to talk about is something that we called enhanced facility surveillance, and that will become clear. I'm going to talk about the rural community surveillance, which Busiko has very nicely brought that in. And then I'm going to talk briefly about an urban community surveillance system. And then finally, I'm going to talk about some genotyping and using the power of genetics to really try and pin down what's going on and whether our operational responses are appropriate. So first of all, the enhanced facility surveillance. This really came about from the malaria indicator surveys, where we were looking in Lusaka and we found that there was essentially no malaria that we could find in the under 5s. Yet if you look at the caseload of suspected malaria cases and also the number of ACTs that were being dispensed, it was really very, very high. So we wanted to really revisit the WHO case definitions and strengthen their use and the definitions that were being used in the clinics to ensure that the data coming out of the facility really was something that we could trust. And it's important to note that the Zambia MOH has really strengthened this by requiring confirmatory diagnosis, as suggested by WHO. Okay, so very much we're pushing that suspected malaria, confirmed malaria, and clinical malaria was misunderstood in the way which it was being applied. Okay, so the two phases of this enhanced surveillance at the facility level consisted of firstly sending out teams to the health facility which went through all of the historical paper-based registers and compiled aggregate numbers of those definitions of malaria. Once that had been completed, there were monthly visits to each of those clinics, again giving feedback and talking clinicians and other health facility workers through the data that was coming out of the system and how it impacted their work. So this chart here shows, I'm sorry, it's rather small, but the blue line is the enhanced surveillance. So this is the one where we directly went in and measured the caseloads and so on. And the red line is the standard HMIS approach. So this is through conventional reporting. The red line determines where, before this red line, this was historical data collection, and moving forward from here, there were monthly visits to give feedback to the workers there. And this is the total number of suspected malaria cases. As you can see, that prior to that red arrow, there wasn't great agreement between the two, but soon after initiation of monthly visits, there was very close agreement between the standard reporting system and our work, working from the raw data. So we think that this really demonstrates the need to push data back down to the people who are actually collecting it. It shows the weakness where you don't have a system that closes the gap. At the same time, feedback improved adherence to the policy of only giving out ACTs to those who are confirmed positive. So our testing rate increased. We can't take all of the credit, obviously, and there's so many other things happening, and we don't think this is the only reason why testing rate has improved, but we did feel that it was certainly part of the solution. At the same time, where number of courses of ACTs being dispensed in blue rapidly dropped off over time. Putting that into an economic context, we calculate that this would be savings of $70,000 a year alone, just in not overprescribing with the ACTs. So I'm going to switch tack from that. I really just wanted to show from the enhanced events that, again, data is power, but you need to inform everyone in the tree about that data. So I'm now going to switch to the work that Basiko introduced on the step 3. So this is, again, working down in Southern Province. And just to very quickly recap, for anyone who missed the last talk, we have a positive case detection arm. Any positives are then followed up, taken to their home, test and treat in the radius around them. And that's all recorded and sent in by mobile phone to the DHS2 platform where everyone can see it. So I'm only going to talk about a small part of Southern Province. The Step 3 is actually now active in 8 districts. We have over 1,400 community health workers trained and reporting this data. But I'm going to look at the initial 3 districts where it was rolled out. That gives us the longest amount of time, and we've also gone through a number of quality controls with them. So This is a very busy slide, but this describes Southern Province. This is actually taken directly from the DHS2 platform, so you can get facility maps very easily. It shows in the white circles, this is the health facility, and the little huts are all of the health worker posts. And the data that I'm going to look at is from February 2012 to August 2013, when we started the Step 3 activities. So again, I just wanted to emphasize with this that moving to health posts gives you much more granularity of detail. It allows you to look whether there's transmission occurring across multiple catchment areas. So in terms of system capacity, all of these charts that I'm going to show have in blue the data from the facility and in red the data from the community. So as you can see, we started in 2012 with the red. Oh, sorry, let me get back. With the red line here. And you can see that in terms of, so first chart that I'm showing here is essentially the number of suspected malaria cases. The community health workers were only trained with RDT usage. They weren't trained to test for any other disease or to really dispense anything other than ACTs, sometimes Panadol or some other analgesic. So you can see that they actually match very closely, which is interesting. You see the seasonality coming through from the community, both when you're looking for the suspected number of cases and also the confirmed cases. So comparable numbers, both facility and community, and this strongly suggests to us that we're identifying additional cases which otherwise wouldn't have presented. We don't see that the facility numbers drop significantly, although we do see that there is a slight impact in the areas where we've rolled out Step 3 activities, the community surveillance. There is a slight reduction in facility presentation of malaria symptoms, but not an enormous impact. So we think we're really essentially increasing the access to healthcare in these settings. This slide here shows the total number of outpatients in the facility versus the total number who are presenting to a community health post. You can see that there's a large discrepancy between these two. So essentially there's a large symptomatic population that are presenting with non-malaria-like symptoms, and we're now wondering if this is a threat to sustainability. If we see that as we progress towards elimination, that people attending a health post, they attend a health post, and then all that happens is they get tested, they're found to be negative, they're going to stop attending that health post. And I would strongly suggest that this is something that we need to take care with. And so we're now looking into expanding the repertoire of services that community health workers can offer, even if it's just to strengthen the referral system or make sure that there is a reason for them to go to this localized network rather than always attending the health facility, which may mean that they don't attend the health facility. So when we look at a breakdown of these three districts in terms of the positivity rate, so coming from the health facility in blue, the community in red and green, either as a component of the passive detection or the reactive case detection, we actually see overall that there's very similar positivity rates found between the three. And we were concerned that potentially we would find that, we think that we're selecting for the same population. And we're particularly surprised that the reactive case detection showed exactly the same as a passive case detection. In some cases, we found higher positivity rates. So we think that this is a tool which is identifying or selecting for a population which is more at risk, and I think that this suggests that is the case. We wanted to look at the impact of wet and dry season. A lot of people are focusing on dry season and whether it's as efficient to find cases in the dry season versus the wet. Interestingly, this is now number of confirmed cases. We find that both by community or health facility, we find similar numbers of cases, and in each case the relative proportions of the reactive case detection versus the passive case detection is very similar between the two. The question which we don't know is if we stop in the dry season, does this lead to here, or how much importation is there? We're still trying to work that out. But it appears that we're equally effective whether we put this intervention in the wet or the dry season. But obviously, our usage massively decreased, so we now need to really look at what do we get bang for buck on RDT usage between wet and dry, and whether we perhaps stop the reactive case detection in the wet season due to logistics problems of getting supplies to people. If you want to discuss this a bit more, Zunda Chisha is going to be presenting a poster at Saturday lunchtime, which you're all more than welcome to come along and ask him some more questions. Okay, so the last surveillance system that I'm going to talk about is the community surveillance in an urban setting. So this is essentially step 3 within Lusaka. Again, very quick recap of the system. The main difference is that there is no passive case detection at the community level. Because everyone's living relatively close to the health facility, there's no need to roll out a network of community health workers testing symptomatics. The other thing is that there's a team response, so it's more of a professionalized response. It includes a nurse and an environmental health technician. And as a result of that increased capacity of the team, we were able to collect additional data points, including GPS. So here we have the data positivity rates that were coming out from the health facility versus the community. And again, bear in mind that this is just the reactive component. There's no passive component in here. But the positivity rates were significantly lower than that seen at the health facility. It is worth noting that that the levels in Lusaka are significantly lower, so perhaps the epidemiology suggests that reactive case detection is perhaps not quite as efficient at lower levels. Nevertheless, we are still finding significant numbers of cases through this reactive case detection. So, yeah, one of the challenges is that positives are relatively rare events. We also have an exclusion criteria with this reactive case detection, which is that we exclude anyone who has had travel in the last month, and that knocks out 75 to 8, well, maybe a little bit more than 80% of all positives. We're also dealing with quite a different population, much more mobile. And so the system could be very much noisier. We also find that it's possible with the mobility of the population that when we travel and test that we really catch less people, and that's something that is a challenge. So this is just a schematic showing some of the responses. It's not important that you take in the details. The key thing is that you start seeing that there are some clustering happening in these different clinic catchment areas. And we really want to know what that clustering is due to. Is it due to importation because people are traveling in those areas? Is it due to local transmission? And that's where genotyping really comes in. We really want to know what is happening where and how that affects our operational responses, and whether we can differentiate between, particularly the obviously imported cases in an elimination setting. If you can't differentiate between the two, as we were looking in Zanzibar, there was comments about how do you make sure that it's not just imported malaria and where it's coming from. You need that to determine what your response is going to be. So we've been working with Harvard, who are the real experts in this field. But just to run through some of the concepts behind it, basically if you have a population of mosquitoes biting a population of humans, and they're infected with many different types of the parasite, many different strains, you get high genetic diversity being passed around and high genetic diversity being created. As you start moving down the continuum from high to medium to low transmission, you start to see that genetic diversity both in the parasites and in the human host reduce. So by the time you get down to very low levels of transmission, you get clonality appearing. So that can be expressed in terms of complexity of infection. So you can look at this as a way of measuring the transmission rates when you haven't got good entomological data. So if you were to plot that in terms of number of unique barcodes, you would find in high transmission areas that they're all unique. When you start moving down to lower transmission, you start to find that there are repeated barcodes or repeated genotypes, and so on. So there's a very nice paper that Rachel Daniels has been looking at this in Senegal, and they have literally seen this happen over time. As transmission drops, they see more and more of the barcodes are shared, and there's clonality appearing. And this is something that we're really interested in looking at as well in Zambia. So the other thing that we want to do is to start really looking at whether genetics can really tell us something about our operational responses and inform the procedures that we have. So currently, if you were to test in a reactive case detection, all that you can say is that these 4 individuals are infected. When you start applying a barcode to them, you can start to see that these 3 have the same barcode, this one has a different barcode, and where you have access to samples taken from around the country, you may be able to confirm that that's actually an imported case due to travel. Similarly, when you perhaps repeat in the same area or close by the following year or whenever it is, you may be able to identify that there's a new variant appearing, or if it's the same variant, you know for certain that you haven't managed to wipe it out. So we think that this gives us a lot more granular detail to answer a lot of the questions that are coming out. So to support all of this, we think it's really important to build capacity in country. As was mentioned in a previous talk, if you haven't got PCR and you haven't got the molecular tools, it takes a very long time to get feedback. So fortunately, we have some very kind donors who have helped us to build this modular container lab. Don't be fooled by appearances. This is a very high quality, very capable system. We've been very impressed with the speed which we can roll these out. So from the time of finalizing the design to delivery was 6 weeks. So that's in country. You go from having nothing to having a fully functioning molecular lab. So this really is a very powerful tool. It's also movable. I really like them. I'm quite an advocate. So if you're interested, please come and talk to me about these. So we're really at the start of this whole process of analysing these samples. Initially, the challenge was really we only have RDTs to work with for most of these samples. We don't have the dried blood spots. So first of all, could we really work with the RDTs as a good source? What was their stability like? And some of this data comes from some of the original or some of the older samples, which perhaps weren't stored in the best way. But nevertheless, we were still able to get pretty good recoveries. And I should say that this was all done with Harvard over in Boston while we've still been getting our system up and running in Zambia and getting the lab in place. But when we look at a principal component analysis, we don't find that there's any significant clustering between the different clinic populations that we've managed to type. When we then look at travel, again, we don't see that there's any real clustering between people who have travelled or not travelled. And I think that the reason for this is that it's to do with the fact that we didn't manage to get full coverage of all of our samples. So to start with, we've targeted just the RDT positives. We haven't started looking at the RDT negatives. And within those RDT positives, as I was saying, some of them are really quite old samples and we weren't able to recover DNA from them. So I think that this represents an incomplete data set at the moment. So I'm not going to draw many conclusions from this, but I just wanted to show you where we were at the minute. In terms of conclusions for everything, I think that we've really seen that data empowers users, it changes behavior, it changes reporting behaviors, and unless you empower everyone in every part of the system, you can have the best central system, but it needs to be disseminated down. In terms of conclusion on community-level surveillance, we believe that it's definitely increasing access to care, reducing barriers to care, but we're not losing quality through that. We're finding that we're able to get this granular detail to focalize, to get this focalized data and target interventions and try and map disease. And this is a very scalable response. It's integrated with the rest of the healthcare system, and it leverages the community health workers. In terms of genotyping, we believe that we're going to be able to use this to really define our operational response. So the questions which are coming through about the range of a response, I think that genotyping will be able to answer that. And obviously verifying malaria-free status or confirming the onward malaria-free status, again, is only going to be possible if we can really differentiate between imported versus local. There's a massive group of people who have been involved with all of this, all the people at ACROS, NMCC, and our funders, MSEPA and PMI. I'm sorry I missed out your slide, your logo. But yeah, there's a huge team, and I think watch this space. Hopefully next year we'll have some more interesting data on the genotyping to really break it down. Thank you very much for your time.
thanks very much, and I'll ask if there are any questions from the audience. If you can please identify yourself.
Hi, Michelle Shang from the UCSF Global Health Group. Thanks for your talk. Just a few questions. Can you talk a little bit more about the genotyping methods that you're using, and in the lab that you've set up, what assays you'll be doing there, and what samples you'll be running there?
So our plan is to really use this as a springboard for a huge number of samples. I won't go through all of it, but certainly we don't plan to just do genotyping. It's a molecular lab, not solely a single assay lab. In terms of the techniques, so we're using the barcode system that Diane Worth's group developed with Rachel Daniels and Sarah Volkman, who's here. So these guys really developed the system, and we're aiming to roll that out. And yeah, that's what we used for the principal components analysis. So it's a 24 SNP based system, but there are plans to move to a bigger system for complexity of infection if that's needed. Does that answer your question?
Yeah. And would that barcoding work be done in country?
Yeah, the plan is. So the plan is as much as possible to do in country, but obviously there's challenges with throughput. So I think that the plan will be to do certainly some in country, some in Harvard, because they have more machines. But yeah, we want to have it up and running, and I think it's also stronger with multiple centres. So we're also working closely with the team down at Matcha, who we aim to try and distribute to make sure that the quality assurance is high. So yeah, we'll be sharing samples between the 3 sites is the aim. Yeah.
And then in terms of using the community health workers for active surveillance, can you talk a little bit about the coverage, the screening coverage that you're getting for reactive case detection?
Do you mean population-wide?
Yeah, like how well are you capturing the residents of the households that reside around the index case?
I'm not sure that I fully follow, but in terms of, I haven't got data to say that we capture 90% of the household members. I couldn't give you a figure on that. One thing that is important to note is that I think having a community health worker is a very different system to a centralized response where you have a really limited timeline and you're perhaps unaware of local conditions. So we found that community health workers are an incredibly valuable resource. They're extremely diligent in the way that they approach this, and they often do repeat visits to make sure that they capture. One of the things that we are looking to do, so all of the data is being sent as an aggregate version through the mobile system. We're now going back and we're taking in the original registers, and we're now going through and making a more complete database of really what happened where, what were the linkages, how many did we follow up, because we didn't want to overburden the community health workers with 100 data elements to collect, and we knew that the quality would drop. So we focus on core elements, number tested, number treated in the different passive and reactive, and that's really our emphasis at the moment, yeah.
Thank you.
Hi, I'm Ken Campbell from PATH. Just looking at the range of presentations this morning, I'm struck by always, is there something new coming out, or is this just progressive, on track, based upon some preset paradigm? And the thing which keeps impressing me, and I assume everyone else in the room, is the prevalence of asymptomatic parasitemia, even after there's been a fair amount of control of quote-unquote malaria. And I guess the question, there's several questions that come to mind, that obviously the objective, the end goal of this is to get rid of all of those infections because they represent the barrier to eliminating quote-unquote malaria or quote-unquote parasitemia. But on an interim basis, I'm trying to understand is how do we understand what that high prevalence of parasitemia represents in terms of transmission that has occurred recently, or transmission that can occur because of the force of transmission. And that's not, to me, that's not an academic question, because it potentially helps understand interventions in terms of where a program needs to be more and more aggressive about getting rid of that transmission, and a signal as to where transmission has occurred recently. Now, there is and I know that this is being thought about, but I'm also reflecting on David Caslow's question a few minutes ago. Are there, with all this fancy genotyping, aren't there methodologies that could help sort out where the force of transmission and recent transmission is occurring, and is that evenly distributed across all asymptomatic parasitemias, or is it focal?
Okay. I think, so the first thing is that I would say that genotyping is not something that is going to be done on every sample. It's not a diagnostic, obviously. It's going to be used in a very focal manner. So I think genotyping does add to understanding, particularly the operational responses. I mean, the questions are being thrown out constantly. How big do you need to test? How big an area do you need to test to capture? Let's assume you have a perfect diagnostic. If you don't test everyone, or if people live outside that area that you test, then your response is not going to be as good as it could be. So I think understanding that is uniquely answered by molecular techniques. Whether genotyping is still going to be, or this particular genotyping is going to be around in 10 years, we may well have another answer for it. But I can't see, and if you can see another way, then I'm all ears. But I can't see how we can answer that question otherwise. I don't know if that was all right.
Yeah, hi. My name's Steve Lindsay. I'm from Durham University. I was very intrigued with your presentation, and particularly looking for clusters of malaria cases in the urban environment. And the question is, what do you do about it? And one of the things I would suggest that you do about it is look at where the breeding sites are in those areas, because it may well be that there is some prominent feature, blocked drain or whatever, that's causing those clusters. So getting people in there to target, either with environmental management or with larval control, may be the way to finish off those hotspots.
I'd agree completely. I think that there's a process that we move through. First of all, we need to get good surveillance data. We need to be telling people what's happening. People need to then start making decisions and thinking about what the responses are. And that's the area that we're at, I think. Deciding how do we respond, what threshold do we respond, how do we map this. So we're looking very much at risk maps and looking at other mapping techniques to see if it tracks with any other features. I'd agree completely. Yeah.
Thanks. Last two questions.
Larry Barrett from PMI, and thank you for the shout-out. We'll get you the logo. My question is a practical one regarding the size of the area that you do reactive case detection and how that was decided on, and whether you've looked at the data since you've been doing this to determine whether, in fact, that's the correct, whether it's too big, too small, and particularly in the urban context, whether that makes sense as opposed to a rural context.
Okay, so I'll talk about the rural context first. The number actually, so as Basika said, the football pitch came really from the mass screen and treat data. So that gives you a unique snapshot of positives within an area. So work done by David Larson, really analysing the spatial patterns of that, showed that when you progressed out past about 75 metres, you were back down to just random chance. So that was the 75-metre mark. We didn't know if that still held in a lower transmission setting, in the step 3 settings. And we also wanted to have a confidence that we were going to contain it. So we decided we want to go slightly bigger than 75. We also needed to operationalize it to a concept that could easily be understood without giving out tape measures. And the other thing that we did is we looked at the classic kind of a household setup in these areas. So we basically enumerated a number of structures and looked at the distances between structures, and we found that generally speaking, if they were over 140 metres, there were many more metres past 140. So 140 contained that focus, as it were. when you went out with that, you were going up to, you'd need to go to 500, 600, or something greater, as a general rule. So that's how we came up with that idea that it's really one cluster of households that are connected, and out with that, it's too big to ask the community health worker to respond. And that's the other point, that you've got people who only travel to the clinic once a month. They can't carry thousands of RDTs, limited capacity. You're asking them to leave their fields if it's harvest time or something. So it's bearing in mind all of those operational constraints as well. In terms of in the urban setting, so the urban setting is slightly different. We didn't have a distance, but rather a number of households, and that was based again on operationally being able to respond. We haven't got the data to say whether we're really containing it, but I think genotyping will answer that. My guess is that we'll find that it's a bigger area. That's my personal opinion, but I haven't got any data to back it up at the minute.
All right, thank you.
Thanks.
Hi, Steve Meshnick from UNC. I sort of want to make a comment about the genotyping on the individual level. And I both in my lab and in other people's labs, that those PCAs you've shown are kind of standard. Unfortunately, either using barcodes or microsatellites or other methods like that, the resolution power is really, really may not be good enough on an individual level to do contact tracing. So my question is, do you have any plans to go to sequence-based tracing?
Not at the moment. Certainly we're keeping all of the DNA that we recover. We're dealing with very small amounts that we're recovering from the RDT. So I think there are challenges there as to what you can do with it. At the moment we're not, but perhaps we'll explore that as time goes on. And I think it's important saying that this is really a platform that we're aiming to do a whole host of other things to drug resistance, and it's really trying to build up the capacity, not just to answer one question, but to really inform a number of other areas.
Thanks very much, and I'm afraid we've run out of time. So let me thank the four speakers. I think we had an excellent set of presentations and a very intriguing sense that countries are really moving towards quality information and granularity on their data, and this is a categorical shift that we're observing in our efforts as we move towards elimination. And so my congratulations to the programs and their partners in the midst of this effort. Andres, do you have any final?
No, not just. It's so clear that we have major challenges, but also exciting opportunities. New strategies, new technologies are there, open for try and error. And so I think we're into an extremely exciting period now with regards to malaria control. So I also want to thank you, all the participants, and also all those interesting questions that came from the audience. And thank you for coming.